Thank you, Madam Chair. And thank you for the comprehensive description of all the services that we wish to restore funding. Obviously, we can't restore everything, so I just want to highlight a few things that I think are worth mentioning. Podiatry on your item number 7. Right now, I believe podiatrists are not the beneficiaries of Medi-Cal. And when you look at diabetes as the #1 cause for amputations in the country, I believe that they should, especially with the shortage of primary care physicians that we see in the state of California. They're a very important member of the team of healthcare professionals, and I hope that maybe somehow we can include them in the Medi-Cal program, so because they see these patients on a regular basis as they go to them to have their peripheral neuropathies addressed, and that's one of the reasons why they have so many foot amputations. In addition, I know it's not listed, and I'm not suggesting that we increase the spending, but maybe redistribute some Medi-Cal funding. A lot of physicians, allopathic physicians in the state of California, don't accept Medi-Cal. We have a College of Naturopathic Medicine in San Diego. I took a tour of it about 2 weeks ago, and I was very impressed with them and their clinic. And they could partner with us at the state level to see, cases going to what would be considered an urgent care versus going to an emergency room because they can't find a physician to take Medi-Cal. So they could be a bona fide healthcare professional that's willing to take the Medi-Cal and kind of ease that shortage in the state of California. We know that the state Deni-Cal program has come under a lot of criticism with the Hoover Commission, and I'm very pleased to see that we're considering putting more money into that program. I'm especially concerned about children, because when children go to school and they have toothaches and they don't have the ability to go to the dentist, it affects their scholastic abilities in school. So even though we restored the 10% cut, the fees remain so low that it's hard to get more dentists to participate. Hopefully we can address that.
Senator Stone, before you move on from issue 7, would you mind?
Yes.
I heard you say that there will be new cost estimates identified, I guess, and may revise associated with these restorations. If either LAO or finance can tell us the basis for the change, why new numbers, and do we have a sense of just how big those numbers could potentially grow to?
Yeah, I'm Jamie Talk, Department of Finance. As the LAO mentioned, I think the optical lab piece was the one where the change in the estimate was, and we could definitely provide more information to the committee on that.
So it's only that service, it's not all of them?
Our understanding is that the administration will be providing revised estimates for all of the services.
All of them, okay. Got it. Do we have a sense of why the change? Was it just do we know why?
I don't know.
Okay.
I would have to defer to the
Oh, here she comes. Thank you.
Mary Kasich, Department of Finance. We're still reviewing the change in the values, but we will get back to the committee as soon as we're clear on what.
Doing the recalculation. Okay, but we do know that they'll be going up, not down. That's safe to assume. Okay, all right, thank you. But I'm sorry, Mrs. Senator Stone. I just wanted to get that clear while we were on that item. Thank you.
Just a couple more issues. Under the Medi-Cal program today, we allow beneficiaries to get tested for vision, yet we don't cover the cost of glasses. It just seems logical that we're going to pay for something and we don't give them glasses. What's the purpose of doing the examination, right? Except for they test for things like glaucoma and things like that, which is very important as well. So that's another thing I'd like to see looked at in this budget. And then item number 16, physical therapists performing electroneurotomy, myography in Medi-Cal. That's nerve muscle diagnosis pathologies. It's my understanding that there are less than 30 physical therapists that have this special designation to provide this service in the state of California. I think it's important to let those that have been that further their education and have gotten certification to be able to do this. I would opine that the costs are probably de minimis in the state with just, 20 or 30 professionals in the state of California providing this service.
So that's a support.
Yes.
Yes, got it, okay. Senator Monning.
Thank you, Madam Chair. Thank LAO for their surveillance on this and staff for the framing. It's helpful to have it kind of all in front of us in this fashion. I had a question on item 7 on the restorations, the adult dental. That 98 million supplements the current funding for adult dental?
That's our understanding. This would be the full restoration, so in addition to
To achieve full dental services for adults. Do you know what the current funding amount is for adult dental?
We don't have that offhand, but we could get back to your staff with that.
I think we have it. I just wondered if you had it at your fingertips. And then on item 36, the Song Brown program to increase residency programs for primary care physicians. The total amount there is 100 million one time. Is any of that to compensate for what we lose from what had come from California Endowment? Do you know?
We don't know offhand. We'd have to refer to the stakeholders for that proposal.
Oh, okay, perhaps when we hear from advocates, we'll get some clarification on that. Again, I know the state was the beneficiary of a 3-year one-time grant from the California Endowment to help support the residency scholarships for residency, loan repayment for residents working in underserved areas. And part of this proposed allocation clearly supports that program. And I was just trying to get a sense of how much of that is expanded support, or is it filling in for the loss of the California Endowment grant? So maybe somebody will be able to elucidate on that. I see Eduardo up there, so great. Okay, those were my questions, Madam Chair. Thank you.
Thank you. Here, I'm going to hand you the letter in terms of the proposal that we got. Thank you. A couple quick questions for me of the department, of LAO. On item 31, the Strong California Boys and Men of Color Investment, do you know if the point of the proposal is to re-grant the dollars to the community-based organizations? So it would be a re-granting kind of scenario?
We would have to get back to you on that
Okay.
or refer to you to the individuals proposing it.
Okay, great. On item 25, the biomonitoring program, because it's the recommendation is coming from the advocacy community, I'm wondering if the actual departments have weighed in on the proposal at all.
We have not heard from the departments regarding this proposal.
Okay,
Yeah, and as the administration, we, at this time, would not be in support of the proposals.
got it. Okay, with that, Dr. Pan, who's in sub 4, requested to come over and provide public comment to one of our recommendations, so I'll ask advocates to accommodate him when he arrives so we can go back to sub 4. We want to thank Finance. We certainly hope that in the Christmas Comes Early package of May Revise tomorrow, that some of these proposals perhaps will be included. Hope springs eternal. But thank you, LAO and Finance, for weighing in on them. And thanks to all of you who are here in the room who've put such thoughtful consideration into the important investment opportunities for the state of California. Again, we're going to open it up. I'm not going to give you a time frame because we're asking you to comment on, for some of you, a variety of proposals as you reflected in your letter, but I would ask that you be mindful of your fellow colleagues who are standing toward the end of the line, that they'll have to stand through the whole presentation. So let's start with the first witness.
Good afternoon, Madam Chair and members. Here in support of item number 3 and item number 6. First, starting with item number 6, the delay of the newly qualified immigrant wrap. Based on discussions, currently DHCS and Covered California aren't quite ready and are not in shape to move that proposal forward right now, and we do hope that there is a delay. Certainly, there could be challenges for those newly qualified immigrants, non-citizens, with the IRS if there isn't a delay and these situations aren't worked out. And if there are challenges with the IRS, certainly that could pose challenges for adjusting status and naturalization. So we do ask that that proposal be delayed.
And you're confident that the one-year delay is enough time to get it worked out?
Well, we're not too confident. I can't say 100% confident that 1 year is good enough, but we do think that certainly some work can happen to move things forward in a better way.
Thank you.
On item number 3, we're also in support of expanding Medi-Cal regardless of immigration status. Certainly, we have 1.2 million Californians who have been explicitly excluded from health care coverage. We are excited about the legislature's work and what will happen on May 16th with over 200,000 children, low-income children regardless of immigration status, being able to get health care through the Medi-Cal program. We're also excited about conversations that are moving forward with SB 10 and being able to seek a federal waiver under Section 1332 of the Affordable Care Act to allow undocumented immigrants to purchase coverage in Covered California using their own money. That certainly will allow California to have flexibility to be able to deliver health services in the appropriate manner for our unique population. But we have to remember that we still do have about 1 million people that will be without coverage, undocumented adults, and certainly we appreciate that kids will have coverage, but what good is it to have healthy children if their caretakers, their parents, are not having access to health care as well? We do think that potentially with the United States versus Texas case that has been heard in the Supreme Court, certainly we will hear what comes out of that case at the end of June, and we do, through that case, potentially we could see that if President Obama is successful in having his administrative relief programs move forward, about 54% of the population of the over 1.2 million people that are eligible for administrative relief could potentially become eligible for Medi-Cal. So roughly about 600,000 individuals could move into the Medi-Cal program, and that is money that the Brown administration has already guaranteed as part of services moving forward. So we just ask that the legislature continue to have the conversation as it relates to undocumented adults and finish the job and cover the remaining population. Thank you.
Thank you. Next witness.
Linda Way with Western Center on Law and Poverty. We thank the subcommittee for considering limiting estate recovery, that's item number 4, to what is federally required. Now that people are required to have health insurance, it's a critical equity issue as only the poorest Californians, those on Medi-Cal, are subject to estate recovery. Those with higher incomes that receive subsidies on Covered California are not subject to this, and we continue to hear that estate recovery remains to be an enrollment barrier for low-income seniors. Another critical senior issue relates to issue item number 5, raising the income eligibility threshold for the Medi-Cal age and disabled program. Under health reform, all adults up to 138% of the federal poverty line are eligible for free Medi-Cal, except for individuals 65 and older. People 65 and older have a lower income eligibility threshold, equivalent to about 123% of the federal poverty line. So for low-income seniors with incomes above this amount, they would be eligible for a share of cost Medi-Cal, meaning they would have to contribute over half of their income before Medi-Cal kicks in. We also support the delay of the newly qualified immigrant wrap, item number 6, as key policy decisions have not yet been made for the programming that is occurring right now. Transitioning between Covered California and Medi-Cal and vice versa is complicated enough. Transitioning this population, which requires an overlay of Medi-Cal and Covered California eligibility rules plus tax law when there are remaining issues that have yet to be resolved, raises serious concerns. I'm going to pause there and come back.
No, go ahead. Finish. No, finish, and then we'll have Dr. Pan.
Great. We also support item number 7, restoration of critical Medi-Cal benefits, including the full restoration of adult dental, as access to these services prevents deterioration of health and the need to utilize costlier emergency services. And I would also like to note that my colleagues will also be talking more in detail, but we also support item number 3, covering the remaining uninsured, item number 14, collection of race, ethnicity, language, and SOGI data, as well as item number 14 related to Medi-Cal interpreters. Thank you.
Thank you. Dr. Pan, please.
Thank you, Madam Chair, and I appreciate, and thank you for everyone standing in line. I realize you're all waiting. So I am here to speak in favor of Budget Request 201 for interpreters in Medi-Cal. And certainly, as we have worked together as a legislature, as a state government, to expand healthcare access, expand the Medi-Cal program, we need to be sure that people truly have access. So having a coverage, first step, next step, being able to see a doctor, hospital, certainly you need to be able to talk to the people who you're trying to take care of and communicate with them, right? And so that is something that we need to move forward on so that we can ensure people truly have access to care. In addition, not being able to have effective communications because of language barriers certainly increase not only healthcare costs, but also lead to poor healthcare outcomes. In this proposal, the cost for the first year is $250,000 to set up the program. A full implementation will cost about $15 million a year, but will create also 7,000 jobs for bilingual Californians. In addition, we have about a third of people on Medi-Cal, and 40% of Medi-Cal patients report a language other than English as their primary language in 2014. So this is something that's extremely important to ensure that people have access to care. As a physician, when I see a patient, I need to be able to understand what the patient's telling me about their condition. At the same time, the patient needs to understand my treatment plan. When I am uncertain about what's going on with the patient, I end up doing more tests. That's more expense. I sometimes get less accurate information. We always say the first thing is get good medical history, but that requires being able to understand. In addition, we have situations when there aren't interpreters. People sometimes try to then rely on family members. Well, sometimes a younger family member because they're the one who's going to school learning English, but you don't want a teenager or elementary school child they brought along with them trying to provide you information. There's also the issue of privacy as well. Some things you don't want to have to explain to your family member or friend who's the one who's trying to interpret for you. We really need to have interpreters. And the other thing, I use the word interpreter very specifically because it's not merely straight translation of the language. Some people say, why do a phone? I mean, we need people who actually can interpret what the person is truly trying to communicate. It's not merely a translation of the words. So, yes.
So that speaks to the current program.
Yes.
Where phone, as you said, translation occurs, and so the point of this proposal is to go beyond that.
Exactly.
To elaborate.
Exactly. In fact, I personally have had experience as a director of pediatric clinic here in Sacramento, where we used phone translators, and it did not work very well. In fact, we now use teleinterpreting because you need to be able to see the body language. You need to be able, in order to effectively communicate, ideally also the people understand the cultural context as well. So this is extremely important to ensure we have quality of care in Medi-Cal. I believe actually it will save money in our Medi-Cal system. And so I urge support for this budget request. Thank you.
Thank you very much, Dr. Pan. Appreciate it. Next witness, please.
Good afternoon, Madam Chair and members. Tam Ma with Health Access California. For item number 3, Health for All, I want to align myself with the comments from Mr. Coleman with the California Immigrant Policy Center. We are so very excited that effective on Monday, all California children, regardless of immigration status, will have access to health care in Medi-Cal. And we look forward to sending the 1332 waiver to the federal government so that undocumented immigrants can buy coverage on the exchange with their own funds. And we'll look forward to continuing working with the legislature and the administration on finding ways to cover all adults in California. We also want to concur with the Western Center on Law and Poverty's support for item number 4 on Medi-Cal estate recovery. We think that adults on Medi-Cal, particularly those aged 55 and older, should not have to choose between their home and accessing comprehensive health coverage. We also support issue number 5, the Age and Disabled Program, and aligning the eligibility criteria to the rest of Medi-Cal. For number 6, the NQI RAP, we've also been involved with the conversations around implementing this program, and we and others have discovered that there are, problems with aligning the different rules and systems between Medi-Cal and Covered California together to make the RAP work, and we do, share the concerns of the Immigrant Policy Center as well as Western Center, and therefore ask for the 1-year delay in this program. Item number 7, restoration of Medi-Cal benefits, we support, and also note that these services were eliminated during the recession for budgetary, not any kind of particular policy issues. We concur with Senator Stone's observation that it's silly to provide a screening for vision, but not actually cover eyeglasses, which is why we support Senator Nielsen's legislation on this issue. Item number 14, on behalf of Health Access as well as the LGBT Health and Human Services Network, we support aligning data collection in Medi-Cal with Covered California. We also support item number 15 with regard to interpreters, and just want to add to Senator Pan's comments that state and federal law already require interpreters to be provided to Medi-Cal recipients. Item number 19 and 20, we support the investments in these dental programs because they are good prevention programs. And then finally, we joined the California HIV Alliance, the Hepatitis Alliance, and Project Inform in supporting items number 1, 24, 33, 34, 35. And last but not least, item number 37, we support expanding the loan repayment program in CMSP counties using CMSP funds. Thank you.
Kimberly Chen on behalf of the California Pan-Ethnic Health Network, here in support of a number of stakeholder proposals. I want to in particular highlight number 6, the NQI RAP. Without repeating the comments of my colleagues, I do want to note that this is a particularly vulnerable population, new immigrants, likely limited English proficient, so the risk of losing comprehensive health coverage and being on the hook for requiring to pay back tax subsidies for reasons out of their control, there's a tremendous risk there, and a 1-year delay is really necessary to work through these significant policy issues that we've encountered as this implementation has been moving forward. I also want to express our support for the restoration of the adult dental benefits item within item number 7. So we've spoken to communities of color around the state, asking them in particular about their oral health. Number one, for many of them, no one's ever asked them about their oral health and how their access is. And one of the key issues that they note is the inadequacies of the partial dental benefits, resorting to unscrupulous providers, underground providers, getting those services that they can't get through Denti-Cal. So I think that's putting them at a tremendous risk and also impacts their ability to receive culturally and linguistically appropriate services. I also want to highlight our support for item number 14, collection of race, ethnicity, language, and SOGI data for Medi-Cal enrollees. As my colleague noted, this aligns our efforts in Covered California to collect this data in an effort to reduce health disparities. Being able to collect this information help us identify where our resources are needed the most. Also want to express our support for item number 3, expansion of Medi-Cal to the remaining uninsured regardless of immigration status, as well as number 4, limiting estate recovery, and expressing our support for access to interpreters in Medi-Cal. Thank you.
Michael Arnold, I'll be very brief. I've spoken with you before. Regarding item 8 on behalf of the California Clinical Laboratory Association, we need a true up. There are all these multiple recoupments that are going on. Let's just get rid of those and start with the new process, which is paying laboratories based upon the lowest average rate paid by other payers, which is what we're now doing based upon the new methodology. Secondly, regarding item 9, elimination of the AB 97 payment reductions. When we did that, we had a $40 billion budget deficit. It's only fair for these providers that we bring them back to where they were before we made those cuts. I mean, it's really time to do that for the people who are still seeing Medi-Cal beneficiaries. So we hope you'll do that. It really is time. Thank you.
Thank you, Madam Chair and members. I'll echo what Mr. Arnold just said in terms of the AB 97 cuts, especially for dialysis. They're at capacity. The clinics are at capacity now. It's going to impede the development of new facilities where they're needed, and people who miss dialysis wind up in the emergency room or they die. And so the emergency room costs, I hope, are calculated into the AB 97 costs that seem to be moving around a bit. Also, I'd like to speak to non-emergency medical transportation. These are the folks that drive wheelchair vans, largely dialysis patients, to and from their appointments. And if they can't get the full 4 hours, they don't get the full benefit of it and often have to go back on weekends to the emergency room. So again, there's a cost effect of turning down these folks and impeding access. And finally, eyeglasses for adults. As Senator Stone says, it makes little sense now, and the sudden increase in the estimate is a little bit disturbing. This subcommittee and the legislature sent this item to the governor in its initial budget last year. So the issue has been around for over a year, and now suddenly we have a cost increase. So I'd like to take a very close look at that, and I hope the documents supporting this new cost increase will be made available not just to you folks who need it, of course, but to the public as well, because I think that needs to be checked out very carefully. Thank you very much.
Point well made. Mr. Barnaby, before you leave the mic, would you identify yourself for the record, please?
I'm Bill Barnaby. I'm sorry if I didn't. On behalf of DaVita Dialysis and SciMed. Thank you.
Thank you. You jumped right into your points. We got it. Next witness, please.
Good day. I'm Dr. Lynn Silver, speaking for the Public Health Institute, also for the California Chronic Care Coalition and the California Pan-Ethnic Health Network, in support of the Community-Based Health Improvement and Innovation Fund. I'm also the convener of the organizations in the California Alliance for Funding Prevention, which is called First State Wellness Fund for Chronic Disease Prevention. This proposal calls for investing millions to save billions. Simply put, we believe that $10 per person is not too much to ask for an investment in chronic disease and injury prevention when we spend $9,000 per capita per year in health care. Chronic disease accounts for 8 out of every 10 deaths in our state. It's largely preventable. Just 6 diseases are the cause of 42% of public health care expenditures, or $98 billion a year, yet we are investing shamefully little in the prevention of those conditions. This fund is designed to sustainably invest in strategies to lift entire communities out of poor health, save money, and build a healthier future for our children. The Public Health Institute specifically also recommends a targeted allocation of 5% of the funds to the California Department of Food and Agriculture, Office of Farm to Fork, to support healthy food incentives and community food projects. An additional approach could be that an initial investment could be used to capitalize a 4-year pilot of this innovative fund, the approach used in Massachusetts, as long-term funding for prevention is defined over time. The proposed fund is a prudent investment in the future health and productivity of Californians. The Trust for America's Health found that an investment of $10 per person per year in prevention activities will yield a return of $5.6 for every dollar spent within 5 years. We call upon you to help prepare for the future. The cost of our inaction in health has been too high. Thank you.
Good afternoon, Mary Jan, representing the California Association of Health Facilities, and I'm here to comment on issue number 2, the calquality.org website. We are opposed to the utilization of our skilled nursing facility and intermediate care facilities serving people with developmental disabilities licensing fees for purposes of covering the cost of the calquality.org site. We do appreciate that the site provides information for consumers about long-term care, but the ranking system they use conflicts for skilled nursing facilities, conflicts with existing rating systems in both the state and the federal system. And for ICFDD's performance data relative to those settings is available on the state's publicly funded website or state's funded website. And that provides data about complaints, reported events, survey, enforcement actions and regulatory compliance. And then finally, on behalf of the 1,200 ICF facilities operating in the state, they continue to struggle financially, so any increase in fees will be burdensome for them. Thank you.